Okay, guys. So last 2 days we discussed provider queries, correct? And we practiced examples. Domain 3. Okay. So this domain should be already completed by last 2 days. So provider queries we completed. Clear? This is your CCS syllabus. Okay. So next concepts we can discuss from the domain 1. That should be first demonstrate knowledge of reimbursement methodologies. Demonstrate knowledge of reimbursement methodologies. Remember, guys, these concepts we don't get in the book. All are theory concepts. You need to understand the concept and you need to answer in exam. So be aware of these concepts. These all are theory concepts. Whatever we are going to discuss today, you don't get single concept also in book. Clear? Everything should be need to understand carefully. So we can discuss reimbursement methodologies today. Reimbursement methodologies. So we have total two reimbursement methodologies. Okay. We have total two reimbursement methodologies for inpatient and outpatients. So for inpatients, they will calculate the payment based on the MSDRG reimbursement methodology for inpatient. For outpatient, they will calculate APC, ambulatory payment classification. Ambulatory payment classification. Okay. MSDRG and APC payment classification. We have two payment classifications here, no? DRG and APC. So based on this, they will ask the questions. So MSDRG means Medicare Severity Diagnostic Related Group. Medicare Severity Diagnostic Related Group, MSDRG. So this MSDRG payment classification they will use for the inpatient reimbursement payment methodology. So what is the use of DRG now? They will use for this DRG value. Based on the DRG value, they will get the payment in inpatient coding. Okay. Based on the DRG value, they will get the payment. So if the increasing the value, payment also will higher. Based on the DRG value, the payment also increasing the chances. So how they will calculate the DRG value? Okay. What are the factors affecting the DRG value in the record? So multiple factors affecting the DRG value in inpatient coding. So what are the factors affecting the DRG? Please note down. These are the factors affecting the DRG. Based on this, all the factors, they will calculate the DRG value. Principal diagnosis and procedure, MCC, CC conditions, patient present on admission indicators, POA, discharge status, patient demographics, like age, sex. These all are patient demographics. So based on all these factors, they will calculate the DRG value. So guys, simple. The patient have one principal diagnosis. Along with principal diagnosis, if the patient have CC, MCC, the DRG value will increase. Okay. So these all are the factors impacting the DRG. Clear? Based on this all the factors, they will calculate the DRG. So which software they will use to calculate the DRG based on these indicators, no? Grouper software. If you add all these things in the document, Grouper software automatically calculate the DRG value. No need to calculate manually ourselves. If you add principal diagnosis, MCC, CC, present on admission indicator, discharge status, patient demographics, and procedures correctly, based on the arrangement of your coding, the DRG value automatically added by using the Grouper software. Grouper software automatically calculate the DRG value and it will append. See, Grouper software analyzes coded data to determine appropriate classification based on various reimbursement methodologies like MSDRG or APC. Okay, it will calculate and analyze the coded data and it will provide appropriate DRG value and APC classification both. What is the use of Grouper software?
To calculate the DRG values.
Not only DRG, APC also. It will analyze the coded data to determine appropriate payment classification based on various reimbursement methodologies, DRG and APC. It will calculate the coded data and analyze the value. Okay. So these factors, remember guys, you will get 2 questions in these factors. They will give the question, what are the factor affecting the DRG, like that they will ask. Okay. So now you understood DRG calculation. Based on these calculations, they will get the DRG value. DRG value we need to use in inpatient coding for the payment purpose. Based on the DRG value, they will get the payment. In outpatient, they will get the class payment based on APC, ambulatory payment classification. APC classification. So here we have multiple APC status indicators. Based on the indicators, they will calculate the payment and they will give the pay. So based on APC status indicators, they will calculate for outpatient services. This is the outpatient services. APC payment methodology should be outpatient. MSDRG for the inpatient. So here you will get 2 questions in these concepts. Patient admitted in the emergency department and they discharged from ED. Under what payment reimbursement methodology they will get the payment?
APC calculation.
APC. Patient admitted in the hospital, 2 days they stayed and discharged. Under what payment methodology they will get the reimbursement?
MSDRG.
MSDRG. CPT codes falls under which payment methodology?
APC.
APC. CPT means outpatient procedures, no? Like this, they will ask, okay? Patient admitted in the same day and discharged same day. Under what payment methodology they will get reimbursed? APC. Okay? Like this, they will get the multiple type of questions. Remember, APC should be outpatient and CPT. MSDRG for inpatient and PCS. So here, based on the APC status indicators, they will calculate the coding payment. So guys, one question you will get from this concept, APC status indicators. We have multiple APC status indicators. At least note down one indicator. Because these all are the indicators. Okay, A, B, C, E, I, J. Based on that, they given the Medicaid like that service. Okay. Based on each indicator, they given the service. It was how the payment impact. You will get one question from APC status indicator N. Okay, what is the APC status indicator N? They will ask. So what is the APC status indicator N means? Non-covered services. Medicare carries these codes on SCPC tape as non-covered, which means what are the services comes under APC status indicator N? For that services, no additional payment, no separate payment. These services are non-covered. These are not covered in the payment. Clear? Non-covered services. Medicare carries these codes on the SCPCS tape as non-covered services. Medicare N. Okay. There is no payment for the APC status N indicator services. No separate payment. So note down APC status indicator N means. Noted.
Yes, sir.
APC status indicator N.
Yes.
Yeah. So these are the payment methodologies. Okay. MSDRG and APC. This clear, right? So these factors, remember DRG factors affecting the DRG. Here you will get one or two questions based on the factors also. Now you get idea. Demonstrate reimbursement methodologies APC and DRG.
Yes.
Thank you. Next concept, identify principle or first listed diagnosis and procedure based on the respective guidelines. If they given any procedure diagnose question, we need to identify the first listed or principal diagnosis compulsory. While we are coding ICD coding in the exam, we need to follow the sequencing. First thing, remember, we need to follow the sequence. If you code all the diagnosis, it was not perfect. You need to arrange in the sequencing manner also. Okay. So you need to arrange in the sequencing. You need to identify the principal or first listed diagnosis. What is the first diagnosis that we need to identify? In short form, PDX, guys, principal diagnosis means. Okay. Principal diagnosis are first listed, PDX short form. So how you will get the question and how we need to identify the PDX we can see. This is your question, suppose. You will get case study like this, guys. So we need to identify all the things in case study. Okay, this is suppose your case study. Like discharge diagnosis, admission history, okay, HPI, past medical history, chronic medication, impression. Okay, like this you will get complete document, 3 to 4 pages case study you will get. Here you need to identify the PDX. Okay, in this 5, one diagnosis should be PDX. Then remaining all should be, we need to consider as SDX and we need to select. Then you will get the procedure, we need to select the procedure. Like this, for each case study, we will get 3 questions. We need to identify exact answers based on the documentation. Okay, see here, they given idiopathic thrombocytopenic purpura, chronic alcoholism, type 1 DM, CAD, hyperlipidemia, hypertension. So here, what is the main reason we need to identify? They given in discharge diagnosis itself 6 conditions, right?
Yes, sir.
So in this 6, one should be exactly correct. That we need to identify. What is the PDX in this visit? That we need to identify after reviewing the documentation. How we need to identify that PDX, I will explain now in the record. Okay, how we need to select the PDX in that multiple diagnosis. Selection of PDX. We have some guidelines to select the principal diagnosis. See, UHDDS, note down UHDDS. Uniform Hospital Discharge Data Set. Discharge. Uniform Hospital Discharge Data Set, UHDDS. So based on the UHDDS, provided certain guidelines to select the principal diagnosis. We have multiple concepts to select the principal diagnosis based on the UHDDS guidelines. UHDDS given certain guidelines how to select the principal diagnosis and secondary diagnosis and primary procedure and secondary procedure. How we need to arrange the sequence? It provided some basic guidelines for us. Based on that, we need to select the principal diagnosis. Okay. The first concept should be patient coming with symptoms. Sorry, guys. So PDX means reason for the admission related established condition. Reason for the visit related established diagnosis. DX should be PDX. Reason for the visit related established diagnosis should be PDX. Okay. What is the patient coming for the reason? That reason related established diagnosis should be PDX. Okay. That is the principal diagnosis definition. Reason for the visit or admission related established diagnosis should be PDX. Suppose reason for the visit also directly diagnosis means that diagnosis should be PDX. Definition clear?
Yes, sir. Yes.
Yeah, thank you. Next, we can discuss how to select the PDX. So first concept, patient coming with symptom. Assessment also. Symptom. No established diagnosis found. No established diagnosis found. Suppose reason for visit should be chest pain. Assessment also chest pain. What is the PDX? Here we need to code
Chest pain.
chest pain. Okay, whenever there is no established condition, symptom only consider as PDX. Okay, symptom only PDX. Next, patient coming with chest symptom. Next concept, coming with symptom and unrelated diagnosis also doc. Suppose here the documented patient coming with reason for the visit should be chest pain and documented DM in the assignment assessment. What is the PDX?
Chest pain.
Chest pain.
Chest pain.
Chest pain only. Chest pain. Why we need to complete give chest pain as the PDX?
Because it is the reason for visit.
Reason for the visit. Okay, that is the reason for visit. Because if they find unrelated diagnosis also, we should not give the PDX, guys. Okay, we should not code PDX unrelated diagnosis. Okay, what? No unrelated diagnosis. Now, patient coming with symptom and established diagnosis documented. Now,
CHF.
CHF.
CHF, congestive heart failure, because Here, patient coming with the symptom and they find the established diagnosis, reason for the related established. Again, can you code chest pain?
No.
No,
No.
need to go.
Whenever we find the established related diagnosis, no need to code the related symptoms. No need to code related symptoms. But unrelated symptoms, if they're documented, we can code. Okay? Unrelated symptoms, if they're documented, like suppose abdominal pain. If they're documented, we need to code additionally. Clear? Huh? Clear? We need to code the abdominal pain also here. Okay?
What is
Unrelated
PDX?
symptoms. Tell me.
What is PDX? Chest pain is symptoms. CHF is PDX.
CHF is PDX, abdominal pain is SDX. That's it, no? If they given, suppose patient coming with chest pain, in the assessment they documented CHF, DM, hyperlipidemia also. How we need to code? CHF should be PDX, DM and hyperlipidemia should be SDX. Same like that only. Okay. CHF we need to give. Remaining condition should be SDX. Clear? Huh? Next concept. Patient coming with reason of the admission symptom and they find multiple diagnoses related to the reason for admission. Multiple diagnoses they document. Okay, multiple diagnoses meeting the definition of PDX. Multiple diagnosis reason for the admission related symptoms. At this time, check the DRG value. Check the DRG value. Which condition have more DRG, that should be the PDX. Whenever they documented more than one diagnosis related to the reason for the admission, at that time, we need to check the DRG value. Based on the DRG value, which condition have highest DRG, that should be PDX. That should be PDX. So if CHF have more weightage, CHF should be PDX. AFib have more weightage, AFib should be PDX. We need to check the DRG value. That's it. Based on the DRG, whichever you will get high, that's. But two conditions falls under same DRG value. Both diagnosis falls under same DRG value. Then any one condition considered as PDX, principal diagnosis. Any one condition considered as principal diagnosis. Clear?
Then only one condition will be considered as PDX.
Always one condition only PDX. PDX means first listed or principal diagnosis. Whatever you are coding, while you are coding, whatever you are giving the first diagnosis, that should be the PDX in the arrangement. If you are coding 10 diagnoses, whatever the first diagnosis you are adding, that should be PDX. Remaining all should be SDX. Only one diagnosis, only PDX means one diagnosis. First diagnosis, consider as PDX. There is no 2, 3 PDX.
In case if there is two reasons for visit, like chest pain and headache, and in
Whatever
assessment
it, see that only I am saying, whenever the documented multiple diagnosis, reason for the visit related. Okay, va?
okay.
Not only single reason, the reason for the visit means. Reason for the visit related, multiple diagnosis documented in the assessment. Then check the DRG value. Okay?
Okay. And
Based
where
on the
we check that
DRG,
DRG value?
based on the DRG value, whichever you will get high DRG, that should be PDX. Both conditions falls under same DRG, then anyone consider as PDX. Because we are coding based on the DRG value. Based on the DRG value only, they will get the payment also.
Okay. And where we find that DRG value for
We
the
can't be able to find in the book and all. This is the software thing while you are coding. If you add all these DRG factors, if you arrange code the PDX, SDX, POA, discharge status, patient demographics, automatically DRG value reflect. Okay?
Thank you.
Thank you. Clear? Huh?
Yes.
Yeah. Next concept. Next concept. Whenever they documented same diagnosis, acute and chronic. Both condition have separate subentries. Okay. Both condition have separate subentries. Like we don't have combination code. At that time, always code acute condition should be sequence first. Acute condition should be PDX. Chronic should be SDX. Clear? Huh?
Yes.
Acute condition should be PDX always. Okay. Acute and chronic pancreatitis. In this concept, we will get one question, guys. A patient coming with acute and chronic renal failure. How you will code the sequence? They will ask. How you will code if they documented acute and chronic renal failure?
Acute renal failure first.
Acute renal failure and chronic renal failure, correct? We need to code both. We need to code both right here.
Yes, sir.
Yes, we need to code both. What is the PDX? Acute renal failure. You will get options like code both acute is primary. Code both chronic is primary. Code only acute renal failure. Code only chronic renal failure. Like that you will get.
Sir, if in exam we get the diagnosis with same DRG value, how to find out, sir?
You don't get the like that questions in exam. If you get also, if you have IP knowledge, you need to do, because this exam related to completely IPDRG, ICPT, ICD. No? We don't have book. If you have already knowledge based on the DRG, you need to assay. That's it. There is
Okay,
no
sir.
other.
Okay.
Okay. If you will get one or two questions directly, they will ask what is the DRG value of particular condition. If you are aware of that concepts, you can assign. Otherwise, not. No, you need to select any one option.
Okay.
Yeah. Clear? Huh?
Yes.
Yeah. Thank you, guys. Next concept. When patient have multiple injuries, this is important. How to arrange the PDX? Multiple injuries. Like patient have multiple injuries, we need to code first fracture. If they documented. In this sequence, we need to code, guys. Fractures, dislocations, lacerations, strain, strain, contusion, abrasion. In this sequence, we need to code when patient have multiple injuries. If the patient have fracture should be sequence first. When the patient have multiple fractures, Which fracture should be most severe? That should be the sequence first. There is no fracture, check for the dislocation. There is no dislocation, check for the laceration, sprain, strain, contusion, abrasion. In this sequence, we need to code. Clear?
Yes, sir.
Yes.
Thank you. In this sequence only, we need to code the multiple injuries. Burn. When they documented multiple burns, based on degree, we need to arrange. First code, highest degree burn, third degree, second degree, first degree. In this sequence, we need to arrange. When the patient have third degree burn PDX, second degree PDX, first degree only PDX. Okay. In this sequence, we need to arrange the PDX. And the patient have multiple burns. Suppose patient have right thigh second degree burn, left hand first degree burn. What is the PDX?
Second degree ones.
Second degree right thigh.
Second degree burn. Okay. Second degree burn should be the PDX. Like this, we need to arrange. Clear?
Yes, sir.
Thank you, guys. So selection of PDX clear, right? So after the PDX, remaining all diagnosis should be considered as SDX. That's it. Remaining all diagnosis should be SDX. Okay. So now, based on your knowledge, you can identify the PDX here. This is the documentation. So they given the discharge diagnosis, 6 diagnosis. This is
Sir,
the
what about ulcers? Sir?
which means
What about ulcers? Ulcers, sir.
Unspecified.
Ulcer.
Ulcer
Ulcer
also.
also same highest degree. Stage ulcer, highest stage. When patient have multiple ulcers. And check the reason of the admission also for ulcer. Okay. If the patient have multiple ulcers, check the admission stage also. Admission stage. Reason of the admission also we need to check.
And sir, for dialysis stage 5, in that case also same?
Yes, same.
Okay, thank you.
So now, yeah.
I have a doubt. If
Yes.
patient have unspecified head injury, for
Hmm.
that,
We need to code
what the
unspecified
code?
head injury only. There is no
But
tell me.
if we had contusion as well, head injury
Contusion
and
also.
unspecified.
Here one concept. Whenever patient have unspecified head injury is the treatment related. Okay. Head injury is the main problem to focus. Head injury we can give the PDX.
Yeah, okay. But if patient has head injury and contusion on hand,
Contusion
have to
also
code related
we
to this.
have head injury only PDX.
No, contusion is on hand. For that instance, we are different location.
Remember, head injury we have one concept. Okay. If the patient have head injury and the reason of the admission should be head injury, the patient have contusion or abrasion also, head injury should be PDX. Remaining locations, we need to follow the sequence. For head
Yeah,
injury, we have a separate concept.
Yeah, okay.
Okay. Suppose if the patient have hand contusion and leg injury, not head, or face injury, then contusion should be the PDX.
Yeah, okay, sir. Okay.
Head injury, we have separate concept. Now, so whenever you see the document, check the reason for admission. Here, what is the reason for admission? Idiopathic thrombocytopenic purpura, right?
Yes.
So this is the PDX. Remaining all discharge summary diagnoses like chronic alcoholism, type 1 DM, CAD, hyperlipidemia, hypertension should be SDX. Okay, that's it. Because reason for the admission, they're not given symptom directly, they mention the condition. Okay, for that condition only they are admitting. So that condition should be the PDX. Clear? Huh?
Yes.
Suppose I'm showing one more question to identify the PDX. See here. Here, what is the reason for the admission? Lack of fetal
Fetal
heart.
heart.
This is the reason of the admission. That's related should be the PDX. Okay. That diagnosis related should be the PDX, like cephalopelvic disproportion, the documented stillborn infant, and classical cesarean section, they done the procedure. The C-section. These are the diagnosis. What is the PDX here?
Lack of fetal heart tone.
Lack of fetal heart
It was PDX. It was reason of the admission. If the documented reason of the admission related, established diagnosis, how it should be symptom PDX? It was reason of the admission related. This is the diagnosis. Stillborn infant,
Stillborn infant.
cephalopelvic disproportion from a combination of small maternal pelvis and large fetus, and they done the classical section. These are the conditions. So, what is the PDX? They given the 5 options. Okay, you need to go for the descriptions and we need to find what is the code for stillborn. Whatever it, okay, that should be we need to give. So whenever they find the reason of the related established diagnosis, do not consider symptom as the PDX. See here, this is 13-year-old American female, African American male. He was shortness of breath, used his inhaler and as prescribed but continue having wheezing and SOB. This is the admission. What condition they documented? Moderately persistent asthma with exacerbation, and administered IM epinephrine and intravenous theophylline. So what is the PDX here?
Moderately persistent asthma with exacerbation.
Moderate persistent asthma with exacerbation should be PDX, not this condition, symptoms, right? Not the SOB, wheezing and all, no?
Yes.
Okay, reason of the admission related, established diagnosis already found. Then again, can you code SOB, wheezing?
No, sir, because they are symptom of the condition.
Clear, right? There is no past medical history, social history, family history, chronic medication. If they documented any social history like smoker or past medical history, we need to code that additionally. Here there is no additional condition. Then we need to code this one is moderate persistent asthma with exacerbation PDX. Then there is no conditions. We need to select none. There is no SDX. None apply, we need to select. Clear? Like this, we need to go. Clear?
సార్ ఇప్పుడు మీరు చూపించే కోడ్స్ అన్ని ఆల్రెడీ అయిపోయిందా లేకపోతే నేను ఏమైనా క్లాస్ మిస్ అయ్యానా?
No, now only I selected, no?
అంటే ఆ కోడ్స్ మేము బై హార్ట్ చేయాలా?
It was not by hearting, it was the ICD coding.
ఆ క్లాస్ నేను మిస్ అయ్యాను సార్.
Actually, I didn't explain the ICD.
ఓకే ఓకే
Because
థ్యాంక్స్.
this is the fast track batch, right? Everybody know ICD. So I don't explain the ICD. Okay. Because I need to go with this concept wise, exam oriented wise. Okay.
Sir, can you go to that stillborn session again once?
Let's leave it because I don't know where it. We are not coding now, just we are discussing about the PDX. This is the stillborn.
Sir, here we should code stillborn, right?
Yeah.
The code is not matching actually.
If they're not given the PDX in this codes, what is the code? That only I'm asking you people.
Sir, is
Huh?
P series.
P series stillborn.
Yes,
So
yes, sir.
actually here, then cephalopelvic disproportion, you will get the PDX. Cephalopelvic disproportion. P series, we should not code in the mother record, right?
Yes, sir.
But we will get for stillborn
Only
P
that
series
code we
only.
have.
Mm.
We
Yes,
don't have
sir.
any other code.
No, sir.
Then cephalopelvic disproportionally PDX. Cephalopelvic disproportion should be PDX.
సార్ మనం లీడ్ చేసి వేసే కోడ్స్ ఏమి ఉండవు కదా ఆల్మోస్ట్ ఆప్షన్స్ ఇస్తాడు కాబట్టి డిస్క్రిప్షన్స్ బట్టి ఈ ఓ సిరీస్లు పి సిరీస్లు చేయొచ్చు
Exactly.
కదా సో
Exactly.
మనకి
Everything
లీడింగ్
should be
చేసి
optional.
అదే అంటే
No need
ఏది
to
లీడింగ్
use
చేసి టైప్
PDX
చేయాల్సిన
అంటారా?
అవసరం లేదు కాబట్టి డిస్క్రిప్షన్ బట్టి ఐడెంటిఫై చేసుకోవడం అయితే
అంతే అండి. ఓకేనా? Based on the documentation, we need to go. Now clear PDX selection. Yes or no?
Yes, sir.
Thank you guys. Next concept. Note down this. Demonstrate knowledge of coding edits, NCCI and medical necessity. Demonstrate coding knowledge of edits, NCCI and medical necessity. That we can discuss. This all we don't get in the book. You need to understand the concept and only possible in exam. NCCI, National Correct Coding Initiative edits. National Correct Coding Initiative edits. Okay, NCCI, National Correct Coding Initiatives. So what is the use of NCCI edits? National Correct Coding Initiative edits. No? These edits should be used for the selection of CPT, sir. For while we are coding multiple CPT procedures. Okay, these are the procedure to procedure edits. Edits in outpatient. Okay, in outpatient, which means CPT coding. While we are coding multiple outpatient procedures, we need to cross check that multiple outpatient procedures we can code together or not. any bundling or not. We need to check the bundling issue here. Okay, that procedure was bundled in the primary procedure or not. That we need to check. Procedure to procedure edit. So how we need to check the procedure to procedure edit now? We have one NCCI edit tool in the Google. For exam purpose, no need to remember the tool and all, just remember the concept. They will ask directly what is the use of NCCI edits. So NCCI edits, procedure to procedure edits, prevent improper for incorrect coding combinations. Okay, it will prevent the improper incorrect coding combinations. Like the two procedures we can code together or not, we need to check before coding. If the two procedures we should not code together, we need to skip the second procedure. What is the procedure included in the primary? If we can code, we need to check any modifier we need to applicable or not, or no need to applicable, directly we can code or not. Total we have 3 edits. These are the edits, guys. You will get while you are coding multiple outpatient procedures 019. 019. 0 means no NCCI associate modifier, which means no need to append any modifier. We can code directly. Okay, we can code directly. Sorry guys, I confused. 0 means not allowed. We should not code together. That two procedures we should not code together. Okay, only one procedure enough. Not allowed. We should not code together. One allowed. You may apply to report modifier 59 for the minor procedure. G9 not applicable. The edit code pair is not active since we can code directly. Okay, we can code directly the two procedures. How we will get the edit and all na? If we add one procedure and search, it will show column. If we get 1, we need to append modifier. Okay, if we get 9, no need to append any modifier, directly code. If we get 0, we should not code that two procedures together. Like this, we should not code these two together. Okay, column 1 should be the primary surgery, column 2 should be the minor surgery. Minor surgery, always we need to skip column 2 procedure. Here, concept remember, procedure to procedure edits, we need to check to prevent the improper payments. These NCC edits used only for the CPT codes, not PCS and ICD-10 Okay, only for CPT coding and outpatient procedures. Okay, outpatient procedures. Total we have 3 edits. 0 not allowed. We should not code together. 1 we need to append modifier. 9 not applicable. Directly we can code together. No need to applicable any modifier also. No need to applicable any modifier also. Clear 019.
Yes.
Thank you. Next, medical necessity.
Sir,
Medical
once can you please repeat definition for 1?
0 not allowed. We should not code together. 1 we need to append the 59. 9 we can code directly together. While we are coding multiple outpatient procedures, we need to check the procedure to procedure edit. The two procedures was bundled or not. We can code together or not. Okay.
So 9 means to clear. There are no edits, so we can code directly.
Directly, no append any modifier also. If you get 1 edit, we need to append 59. If you get 9 edit, without modifier, we can code two procedures. If we get 0, we should not code together. One procedure enough.
Okay.
Next, medical necessity. Medical necessity. Medical necessity means if we are coding any diagnostic study or any procedure, if they performed, we need to look for the reason of the procedure, why they done the procedure, for which reason they done the procedure, or for which reason they done the diagnostic study. What is the reason to perform a procedure or to perform a diagnostic study for the patient? For any patient, why they will perform any one surgery or procedure? మీరు ఒక హాస్పిటల్ వెళ్ళారు, మీకు ఒక
condition
ప్రొసీజర్
or
చేస్తాడు అనుకోండి, ఎందుకు చేస్తారు
to
ప్రొసీజర్?
cure.
If we have any diagnosis,
When the
any
patient have
problem.
diagnosis or to identify a diagnosis, they will perform a diagnostic study or procedure. Correct? If the already patient have disease, they do the procedure to treat the diagnosis. If they thought any diagnosis, they need to identify patient have symptom, they will do the diagnostic study. Okay. So same, suppose if they done one EKG service, ECG or EKG, when they will perform EKG?
If
Or
we
when they will
have symptoms
Not
of
if
chest pain,
having any chest pain or shortness of
chest
any
pain,
cardiovascular condition or symptom, right?
Yes, sir.
Cardiovascular symptom or condition, when the patient have, they will perform the EKG or ECG. But in the documentation, there is no cardiovascular symptom or condition, but they done the EKG or ECG in the documentation procedure. At that time, it shows medical necessity edits. Okay, whenever we are not adding the relevant diagnosis to the particular procedure or diagnostic study, it will shows medical necessity edit. Please provide the medical necessity of the particular diagnosis. Okay. So here we have two edits based on the medical necessity, NCD and LCD, guys. NCD edits, LCD edit. National coverage determination, local coverage determination. National coverage determination, local coverage determination. Nation coverage determination, nationwide they will follow the same guidelines. Local coverage determination means region wise. See, for each procedure, they provided the list of the diagnosis. What are the diagnoses covered for the particular procedure? They given the list of the diagnosis for each procedure. Okay. So what are the covered diagnoses for the particular procedure? Also, they given the list. So any procedure, if you performed, the list of the diagnosis, any one, if you added, no problem. If you are not coded, it will shows medical necessity. Please provide the related diagnosis to the particular procedure, because without diagnosis, if they perform any procedure, it won't bill because it was not a need for the patient. Okay. They need medical need. At that time, if they perform procedure, they will get the bill. Clear? NCD, LCD. Just we need to check the related diagnosis documented or not. If the documented, we need to code. If you are not coded, it shows the medical necessity edit. Please provide the supportive diagnosis for the particular procedure. So here one question you will get. Note down. What is the medical necessity of heparin alpha injection? What is the medical necessity of heparin alpha injection? Heparin injection is used to treat anemia in patient with CKD or ESRD. Heparin injection is to treat anemia in CKD or ESRD. Anemia in CKD or ESRD.
Can you repeat the question, please?
So they're asking what is the medical necessity of apiotin alpha injection? What is the medical necessity of apiotin injection?
CKD with anemia.
Yes, that only. CKD or ESRD, okay? CKD or ESRD. Anemia in CKD or ESRD should be the medical necessity. Clear? Noted?
Yes.
Yes, sir.
Next. Medical necessity clear, right? Clear?
Yes.
Next edits should be MUE edits. MUE. Medically unlikely edits. Medically unlikely edits. This also we need to check maximum unit of services. Okay, maximum unit of services. One CPT code, how many times we can code per day? Okay, one CPT code, how many times we can code per day? Sorry guys, suddenly my lap was switched off.